Hi there, welcome back. We are working on Chapter 14, Medical Overview, and this is Chapter 15 in your 12th edition book. Chapter 15 in the workbook is what you should also be working on, both with the title Medical Overview. We're going to cover medical overview and then we're going to cover trauma overview, and there's a difference between the two and what our responses are. Trauma emergencies involve injuries resulting from physical forces, where medical emergencies involve illnesses or conditions caused by disease. Patients may have a medical issue that caused their traumatic condition, and they may have a traumatic condition that exacerbates a medical issue. So you don't just necessarily have one patient in either or, sometimes they can actually include both. There are types of medical emergencies like respiratory emergencies, cardiovascular emergencies, neurological emergencies, gastrointestinal conditions. These are probably the most common medical emergencies that you will end up treating. Urological emergencies is also very common, mostly involving kidney stones. Endocrine emergencies, we see diabetes all the time. And then there are some very rare hematologic related emergencies like sickle cell disease or hemophilia, which is a very small percentage of the population. However, you may be in areas where you'll find pockets of these individuals with these particular diseases that need frequent treatment and or transportation to the emergency room. Allergic reactions are one of the more common immunologic emergencies that we respond to and also provide treatment for as EMTs. Toxicologic emergencies, very common poisoning, substance abuse or overuse, or overdose. And then occasionally, gynecological conditions are a special category that we do get called for medical emergencies, often involving the female reproductive organs. Some medical emergencies are caused by psychological or behavioral problems. Those are actually pretty common as well. They can be difficult to deal with because patients often don't present with typical signs and symptoms, and or they're not forthcoming with the signs and symptoms that they do have, and or they exacerbate their um, problem with the condition. They'll change how they feel about something or treatment, etc. So they become a little confusing whenever you're working with those patients. So again, in your book, you'll see this table as well. It shows the types of common medical emergencies that we will respond to. And as we learn through the course of the EMT program, you'll see that we are going to learn about each specific possible emergency and how to treat or how to provide care for each of those emergencies. First, we complete our patient assessment. Remember, we want to make sure that we are doing a scene assessment as soon as we get on scene, right? But we want to focus on the medical patient on what the nature of the illness is. What is their chief complaint? Why did they call us today? We also need to establish an accurate medical history. We can use the dispatch information to guide our initial response, but we definitely don't want to get locked into that. We don't want to get locked into the preconceived idea of a patient's condition. Always keep our eyes open, our ears open, listen for what potentially may be going on, and try not to tunnel vision into that specific what the dispatcher said it was. Uncooperative or hostile patients, remember, maintain a professional, calm, non judgmental demeanor at all times. Definitely refrain from labeling patients and displaying personal biases. And a frequent caller may have a different complaint this time. So if you're running your frequent flyer and now they're actually having a heart attack, they may call you. You can't disregard their medical emergency just because of their past history with calling you frequently when you weren't needed. So, remembering the major components of your patient assessment, we have scene size up, right? Penman, PPE, personal safety, environmental hazards, number of patients, mechanism of injury, additional help needed, and need for extrication. Our primary assessment, which is ABCs and stopping the bleeding. History taking, that's going to give you, what medications are you taking, what's your past medical history. Your secondary assessment, which is going to be more focused on the area that they're complaining about pain in. And then your reassessment, right? Every 5 minutes for critical patients, every 15 minutes for non critical patients. In your general impression, again, you should know, is this patient does the patient appear to be in extreme distress and has the potential of dying on the way to the hospital, right? Or does the patient appear currently as if they are stable and we have some time before they have to get to the hospital? We can ask more questions, we can do some more deep dive into the investigation. Or is the patient completely stable and we're just going to transport because the patient wants to go to the hospital? So we're determining the level of consciousness. Maybe they passed all of those markers, but we're highly suspect for something could potentially be going wrong and we don't want them to deteriorate. We do our assessment for airway and breathing. Consider applying oxygen at this point if the patient's respiratory rate, depth, or quality is off, or their pulse oxygen saturation is low. If a patient is in shock, is having difficulty breathing, or they have a low oxygen saturation, less than 94%, we want to consider providing oxygen. Unconscious patients may need an airway adjunct. If they have a gag reflex, then we're not going to use an airway adjunct on them necessarily. If their ventilations are below 8 or greater than 28, then we need to consider using a bag valve mask to provide ventilation and ventilatory assistance to these patients. We'll assess the circulation in a conscious patient. For unconscious patients, we're going to assess the circulation at the carotid artery. If it is absent, of course, we're going to start CPR. So we should initiate transport decision immediately after our primary assessment is complete. The following patients should be considered in serious condition and in need of rapid transport: patients who are unconscious or who have an altered mental status, patients with airway or breathing problems, patients with obvious circulation problems such as severe bleeding or signs of shock. If the patient does not meet the criteria for rapid transport, continue to assess on scene and prepare for transport when you have completed the assessment and treatment. If at any time during that assessment your general impression indicates that the patient's level is deteriorating, that their stability is deteriorating, then you can always change your mind about transport decision and be like, you know what, never mind, let's go ahead and get in the back of the ambulance and head out of here. Determine what the problem is or what may be causing the problem. Sometimes the patient is unconscious, so you need to ask your family, friends, or bystanders. One of the hardest things to remember when you're in the thick of it. Investigating the nature of the illness by asking about the chief complaint, right? You want to ask those OPQRST questions. If you're at a scene where somebody is unconscious, there's no bystanders or family members, then you want to look around to see if you can find any evidence of why they may have possibly become unconscious. Remember to obtain the sample history, so your signs and symptoms would be your chief complaint with OPQRST. So onset, provoked, quality, radiation, severity, and time. When did it start? What were you doing when it started? What does it feel like? Does it move anywhere? On a scale of 1 to 10, 10 being the worst pain you've ever felt, what is that pain? Could you describe to me what the worst pain is you ever felt? And then time. Is this the first time this has ever happened to you, or has this ever happened before? Then you want to get your allergies, medical history, patient's personal physician, last oral intake, right? What did they eat or drink? And any events that might be related pertaining up to this. Some patients take numerous medications. Do take the medications to the hospital with you and list them in your report. If you do collect medications from the house, again, make sure they're the patient's medication. Look for their name on there, and that you're not taking other family medications and or you're not taking, pet medications like dogs or cats. Another mnemonic you can consider is tacos. Whenever you're asking about anything related to medications and or drug or alcohol use, tacos is tobacco. Do you use tobacco, alcohol? Have you had anything to drink today? Caffeine. Do you drink coffee? Do you drink soda? Do you drink Monsters? Do you drink? Oh my gosh, there's so many caffeinated drinks out there. And then over the counter medications, any herbal supplements. Those are very important because there can be lots of interactions with regular medications that you provide and herbal supplements that are over the counter. Sex and street drugs, are they using any of those? Those are That's a question that you may not get an honest answer if there's an audience, and or you may get an elaborate answer if there's an audience. It really depends on the person. Scan the scene for clues about the patient's medical history that might help you understand the current medical history. So the secondary assessment can occur unseen, but you could usually do this en route to the emergency department. It really depends. It'd be a focused secondary assessment. It's not a bad idea to just do a quick body scan, make sure you're not missing anything, haven't overlooked anything, or find something that might be related to what the patient is experiencing or complaining of. Um, all conscious patients should undergo a limited or detailed physical exam based on their chief complaint. And then for unconscious patients, always perform a secondary exam, head to toe examination. A full body assessment would help you obtain clues and should be performed quickly so it does not delay transport. When you're examining the head, scalp, and face, looking for possible trauma, check your ears, eyes, nose, mouth, looking for anything that might be running, any blood, any mucus, any fluids. Examine the neck closely. You want to look for any accessory muscle use. Check for jugular vein distension, any tracheostomy or stoma. Assess the chest and the abdomen, checking breath sounds. Palpate the chest and the abdomen. Check for medication patches, rigidity or distension, and scars. Check the pelvis and genital area. Palpate the legs and arms, looking for any swelling and abnormalities. Check for distal sensation and motion and circulation, and examine the patient's back. Based on the conditions that you find, will determine what your treatments are, and what your options are related to your local protocol. In vital signs, we're going to be looking at pulse rates for regularity, rate, quality. Identify the rate, the regularity, rate, and quality of the respirations as well, and any obvious distress or difficulties that may be apparent. We'll get a blood pressure, measuring both systolic and diastolic pressures. And we're going to consider using the automatic blood pressure cuff for future assessments at regular intervals. Consider obtaining a blood glucose level. So if the patient has altered level of consciousness, is complaining of weakness or dizziness, we may want to consider the blood glucose level, even if they are not a diabetic. And then pulse oximetry reading. So we want to know what their level of oxygen is in their body. Once the assessment and treatment have been completed, reassessment should begin and continue throughout transport. Repeat the primary assessment and reassess the chief complaint, and consider the need for any ALS backup. Reassess interventions. Anytime there's an intervention, we should reassess. And we want to document any developed changes and obtain vital signs every 5 minutes for unstable patients, every 15 minutes for stable patients. We also want to review all treatments that have been performed, document any changes that have developed as a result of our treatments, and if needed, adjust any of the treatments accordingly. Most medical emergencies do require a level of treatment beyond that available in the pre-hospital setting. So determining when to take the patient in and expedite is very important part of our critical decision making. Advanced testing is available in the hospital, and often it is beyond the scope of an EMT to administer medications to patients. We can use the AED, and that is part of your CPR training. Scene time sometimes takes longer for medical patients, and if you're working with ALS, then it may take even longer. For example, if you have a diabetic patient with an ALS responder, you may spend some time on scene administering dextrose to see if the patient's blood sugar improves if they are having an episode of hypoglycemia. We do want to gather as much information as possible to transmit to the emergency department. Remember, you're their eyes and ears for everything that happened on scene and anything the patient was complaining about or discussing. Critical patients always need rapid transport, and those are patients that have altered mental status, airway or breathing difficulty, signs of circulatory compromise, and of course, patients who are very old or very young and with their chief complaints. If a life-threatening condition exists, of course, we'll use our lights and sirens. If the patient is not critical and it really isn't going to improve your time, then you can probably transport the patient without lights and sirens. Also, if anxiety will increase the uh, severity of the patient's illness, then we may consider not riding with lights and sirens as well. Modes of transport ultimately come in one of two categories. They may either come in ground or air. Ground transport EMS units, usually staffed by EMTs and paramedics, a combination of EMTs, combination paramedics, or combination of an EMT and a paramedic. Air transport EMS units, generally staffed by critical care transport professionals and paramedics. Locally, you'll find a nurse with their own standing protocols, as well as a critical care paramedic. They will respond together and both have specific functions within a call that they perform. When you're considering ALS support for a patient, compare time for a ground ALS unit to respond as opposed to an ALS helicopter. And if this patient is an extremis, certainly they need the fastest transport available. When deciding a general location, the closest hospital is usually going to be our destination. Sometimes the benefit to a patient may be at another facility that handles their particular condition or situation. That will be dependent on local protocols. Infectious diseases, in our general assessment, remember that we want to always protect ourselves, protect our teammates. So we should be wearing appropriate level of PPE, personal protective equipment. In that scene size up, we're already taking standard precautions, i.e., we're wearing gloves, and very likely some type of eye covering and a simple face mask. We gather the patient history using that OPQRST. We find out that the patient maybe is complaining of fever, nausea, rash, uh, pleuritic chest pain, difficulty breathing, vomiting, and diarrhea, all of which could potentially be infectious. At that point, we may want to consider upping our PPE so that we have more coverage. Obtain a sample history, a set of baseline vital signs, just as any other patient. Ask whether the patient has recently traveled or has come in contact with someone who has traveled. That interesting question about whether the patient has traveled, they had in Canada, in Toronto, during the SARS epidemic back in like 2002, I think it was, when they had the outbreak of SARS back then. Um, they There was a nurse that was working within the Toronto hospital system that was aware of what was happening in the China outbreak of SARS disease, and was actually one of the first to recognize that they were seeing patients in the emergency room that potentially fit the criteria for this new type of disease that they had identified. And as a result, was able to start the process of backtracking to figure out that yes, they were. Toronto was also in the middle of their own epidemic. General management principles: focus on any life threatening conditions identified in the primary assessment, be empathetic, place the patient in a position of comfort as you would with any patient, and use standard precaution. Once you're done with your assignment and making sure that you're cleaning the equipment appropriately according to the agency's exposure control, also make sure that it is noted in your employer's exposure plan that you did have an exposure to an infectious disease. In an epidemic, when new cases of a disease in a human population substantially exceed what is expected, we have epidemics of influenza pretty frequently. At least every couple of years, we'll have epidemics of influenza that go through the population and they exceed what we're expecting for that particular time. And then a pandemic, which we have all lived through. Most of us have actually even lived through the 2009 one as well. We did have a 2009 H1N1 novel influenza pandemic, in addition to our recent COVID pandemic. Flu pandemics are one of the most known, and we'll probably see another pandemic in the next, I would say, 20 to 30 years. Common or serious communicable diseases include influenza. It is a human disease, but it is also an animal disease. So influenza spreads easily. Avian influenza, specifically swine influenza, spreads easily among pigs. Avian spreads easily among birds, and humans have their own influenza. And each of these have the ability to genetically get together and create new strains of a flu virus that can then be transferred over from, say, the bird into the human, or as is the case in 2009, where we had the swine influenza transferred. It picked up enough human genetics that it was able to transfer it to the human and become infectious in the human population pretty quickly. Persons with chronic medical conditions, compromised immune systems, the very young, the very old are always more susceptible to complications of influenza. H1N1 2009 was particularly hard on pediatrics. They saw a threefold increase in deaths related to influenza in the under 18 population during that pandemic. Transmitted by direct contact, nasal secretions, aerosolized droplets from coughing and sneezing by infected people. H1N1 has been present in for years in animals and was initially identified in 2009. It did cause many deaths, and it increased the awareness of routes of transmission. This is one where some of the first studies of masks were used and identified as being preventative in the healthcare setting. So for diseases that can be passed by the respiratory route, always wear PPE, wear the best HEPA respirator that you have, hopefully recently fitted within the last 6 months. You want to wear the respirator, not because it's 100%, but it will decrease the amount of virus that you're exposed to, which then it can do two things: either decrease the actual infection, and or it will decrease it enough that your body can actually fight it off and you never develop an infection. Wear a HEPA respirator during aerosolized generating procedure like suctioning. And then annual influenza immunization is important for EMS personnel, more so not because in our age group or your age group are we that susceptible to bad outcomes of influenza. It'll probably just make you really, really, really sick, and then you'll get better, and then you'll have antibodies to it. But when you're working in healthcare, you're working with a lot of people that don't have that ability, either the very old or the very young. And you becoming exposed to influenza, catching the virus, and then being at work can expose other more vulnerable populations to the virus, which would then make them sick. So that's the biggest reason for influenza immunization, is to try to slow down the transmission of the disease to protect those persons that are in your charge. Herpes simplex, that's a common virus strain carried by humans. About all of those persons carrying 80% are asymptomatic, which there's a large number of persons carrying herpes simplex. Symptomatic infections cause eruptions of tiny fluid-filled blisters called vesicles that usually appear on the lips and or the genitals. It can cause more serious illness like pneumonia and meningitis in very young, very old, and immunocompromised patients. And of course, the primary mode of infection is through close personal contact. That's why standard precautions are very helpful, so you don't pick up any of the herpes virus germs on your fingertips and then transfer them to anything else that you're using or wearing. This is a picture of herpetic whitlow, which is a transfer of herpes simplex from a patient to the hands of a provider. Herpetic whitlow happens not infrequently in the healthcare profession, usually by contamination of a surface exposure. Somebody or something with herpetic or with herpes simplex touched a surface, and then without gloves on, we touched something else. So it really just points out: wear the gloves, wash the hands, use the alcohol hand sanitizer if you can't find any soap and water. And then as soon as you find soap and water, wash your hands again, several times. No, I'm just kidding. But at least, sing happy birthday twice. HIV infection. EMTs face the risk of exposure to the virus that causes AIDS on a regular basis. Of course, there's no vaccine yet that protects against HIV or AIDS. However, the treatment for HIV can make it so that persons that are carrying HIV are actually unable to transmit the virus as long as they're maintaining their treatment and their blood levels continue to show no evidence of the virus. AIDS can still be fatal if a person with HIV actually gets to that point. But with treatment, HIV patients can expect a near normal lifespan. HIV infection is a potential hazard only when deposited on mucous membranes or directly into the bloodstream, and it really takes a significant amount. It isn't a small amount that would cause that. It is not easily transmitted in the work setting, and your risk of infection is limited to exposure to an infected patient's blood and body fluids. So if you ever have an exposure to mucous membranes of any blood or body fluids, and or you have a needle stick injury, then this is the time where you would go to your employer's exposure control plan, and you would then ask them, what do I do next, right? So what's my exposure at? What are my options for treatment, for prophylaxis? And then, of course, they're going to want to do a blood draw to make sure that you wouldn't be HIV positive already going into this exposure. Many patients with HIV actually don't have these symptoms. So always wear the proper type of gloves. Always take great care in handling and disposing of needles and other sharp objects. And cover any wounds that you have whenever you're on the job. So make sure you have an occlusive dressing on those. Don't have a porous dressing. If you think that a patient's blood or secretions have entered your system, make sure to seek medical advice and report it to your infectious disease officer or your direct supervisor. Hepatitis is inflammation of the liver, is what it comes out to. Now, there are other causes of inflammation of the liver that is not related to the actual hepatitis virus. There are different types of hepatitis virus that can be caused by a number of different viruses and toxins, hepatitis itself. But the one that we're most concerned about is hepatitis B. Hepatitis B is blood-borne and body fluid-borne. So if we get that into our mucous membranes or we have any type of blood exposure into the mucous membranes, then potential is that we would get hepatitis B. Now, while many people will recover from hepatitis B, long-term outcome includes cancer of the liver and also recurrence of hepatitis that can lead to liver failure. So we do need our livers to survive. Uh, Early signs include loss of appetite, vomiting, fever, fatigue, sore throat, cough, muscle, and joint pain. Several weeks later, the person may experience jaundice, which is that yellowing in the sclera of the eyes and yellowing in the skin, depending on the severity of the liver failure, and right upper quadrant abdominal pain. Toxin induced hepatitis is not contagious. The only ones that are contagious are hepatitis A and hepatitis B. Hepatitis B vaccine is available for the and hepatitis C, but not as much. Hepatitis B vaccine is recommended for EMS and for anybody that provides any type of patient care. Hepatitis A, if you like to eat out, I recommend the hepatitis A vaccine, or if you like to visit other countries. Hepatitis E is transmitted primarily through oral or fecal contamination. So, for example, the person taking care of the buffet develops hepatitis A, goes to use the restroom, doesn't wash their hands, comes back and handles the lettuce and the buns, like the bread or something like that, and then they transfer that over to the food that you're about to eat, and then you become exposed to and potentially infected with hepatitis A. So there is a vaccination for that. That's good to know. These are the characteristics of the different types of hepatitis. If you want to stop on this slide for a few minutes, take a look. I believe the table is also still in the 12th edition book. Meningitis is another disease that you may see as an infectious disease in the field. Meningitis is not always contagious. There are two types, bacterial and viral. Basically, it's inflammation of the meningeal coverings of the brain and spinal cord. It causes fever, headache, stiff neck, and altered mental status. Most forms of meningitis are not contagious. One form specifically, meningococcal meningitis, is very, very contagious. And this is the type that they like to vaccinate for whenever you go into dormitory type settings or into multiple person housing or residential settings, because it is preventable. But more concerning is that from the time of symptoms to death is potentially 24 to 48 hours. So once you actually become sick with this, you're on a very fast route to becoming septic and dying. So you want to prevent getting to that point altogether because it does take time to initiate care, and some people don't make it in perfectly young and healthy persons. So if you run a call where they have meningitis type symptoms, you're not necessarily going to know if it's bacterial or viral. There are a few key points that will guide you in one area or the other. Bacterial, typically high fever, severe symptoms. The meningococcal type of meningitis will cause bleeding under the skin, like little pinpoint rash. It's called purpura. And the other thing is that it is rapid in onset, right? And no report of any respiratory illness or any other type of sickness leading up to this point. Where a viral meningitis typically will not be as severe. The patient is still going to be uncomfortable, but it will not be as severe. The fever should not be as high, and also the complaint of a cold or respiratory illness prior to the week prior to this onset of headache, photophobia, etc., is going to be key, usually leading up to a viral type of meningitis. Regardless, an exposure to somebody complaining of signs and symptoms of meningitis should immediately be notified. You should immediately notify your supervisor, enact their exposure control plan, and then follow the directions that are provided because there are prophylactic treatments available for persons that are exposed to meningitis bacteria and that can prevent the illness altogether. And gloves and a mask are going to go a long way to prevent any of those secretions because that's how it's transmitted. Vaccines can be you can get the vaccine much like they have for um, the dormitory settings. And then, of course, if you had an exposure and they believed it would be related to a bacterial form, then they do have antibiotics they can give you to prophylactically treat. Tuberculosis is not as common as it used to be. However, it does have the potential to make a comeback. Infected patients are, well, most of the time, and whenever they start to exhibit signs and symptoms because they've had a relapse into the tuberculosis disease, that's when they become contagious, when they start to cough, et cetera, et cetera. Chronic disease that usually strikes the lungs, but it can also cause problems in the brain, the kidneys. And if it does in the brain or the kidneys, then they are only slightly contagious, not compared to the coughing or the lung-stricken tuberculosis patient, where they're going to have coughing out the tuberculosis bacteria, which then the responder could be subject to if they're not wearing the appropriate equipment. Patients that pose the highest risk are almost always have a cough. Consider respiratory tuberculosis to be the only contagious form because it's really the only one that's spread by airborne transmission. An N95 or HEPA masks are required to stop droplet nuclei, and they're very effective at preventing illness in the non-tuberculosis patient. Infectious agents can take hold in patients much more easily because of reduced defenses, and those are typically your elderly patients or those that are immunocompromised from chronic illness, cancer treatment, organ transplants, and of course, children. Absolute protection from infection with this does not exist. About 1/3 of the world's population is infected with tuberculosis. Interesting fact. The vaccine for tuberculosis, called BCG, is only rarely used in the United States. We don't have it's an easy one to catch, so we don't have continuously transmitted tuberculosis going on in the U.S. once it's identified, and the mechanism of transmission is not very efficient. So we do the TB test regularly. If you're in a higher tuberculosis area, sometimes they require it once every year, even once every 6 months, depending on your potential exposures. Pertussis is a disease that kind of popped up starting in 2010. It had been kind of just a little bit out there, and then in 2010 it really started epidemic in the United States, and mostly because they understood that the children's vaccine was wearing off and children were becoming more susceptible and that they actually needed a booster, as did many adults who were also coming down with whooping cough. Pertussis is a bacteria, and a bacterial infection can be treated with antibiotics whenever it's initially recognized. However, the historic whoop of whooping cough doesn't actually occur until after the bacterial infection has already struck the body. The body has fought it off, and now all of the bacteria have died, creating a toxin that then filters through the bloodstream and causes this whooping cough attack that can last for a couple of weeks afterwards. So it is preventable with vaccination. If you haven't had a booster in a really, really, really long time, it's not a bad idea to consider it. If you were in seventh grade after 2010, then you probably did receive a booster of some sort already. But as you get older, you may consider getting another one. A lot of times it's provided with a tetanus combo. So every time you get your tetanus shot, like every 10 years, then the whooping cough pertussis vaccine is also included. Now, a lot of hype goes into the MRSA, the methicillin resistant Staph aureus, which can be a really nasty little bug that gets into immunocompromised areas like hospitals and skilled nursing facilities and can cause a lot of problems for the residents that are already immunocompromised. But methicillin used to be one of the strongest antibiotics that we had out there. We do have stronger antibiotics out there now, but another thing is that if an antibiotic becomes resistant to methicillin, sometimes they are still reactive to some of the other medications, other antibiotics that we have out there. So while it may be resistant to methicillin, it may still be able to be. You could do like a penicillin instead that would work on it. So that's a good thing, and they only know that if they do the lab results or if they test it, test whatever the sore is or the infection. They test that part and they find out they can run a profile on it to see what it is reactive to, and then use the appropriate medication to start fighting that particular bacteria. Now, there are bacteria out there that are resistant to just about everything, and those can and do cause significant injury, disability, and death in patients that are infected with them. Um, so, wearing your gloves, washing your hands on a regular basis is one of the most important things you can do to prevent it in yourself. But most importantly, whenever you're working in the healthcare setting, again, you're responsible for the care of the patients that you are taking care of. And part of that is trying to assure that you are not making them ill with anything that you've picked up somewhere else. So making sure that you wash your hands and that you are, cleaning between each patient so that you're not transferring things like MRSA. MRSA results in those soft tissue infections, so localized skin abscesses, and sometimes sepsis in older patients. So MERS-CoV, I think we've learned a lot about coronavirus in the last couple of years, but MERS-CoV was found in Saudi Arabia and akin to other coronaviruses. It was a newer coronavirus, and this one was found in camels. But patients were starting to pick it up. People were starting to pick it up and become patients with a significantly high death rate. It did have all of those signs and symptoms common to new coronaviruses with high fever, cough, muscle aches, vomiting, diarrhea. Renal failure was a big component of the MRSA strain of coronavirus. There are no cures or vaccines for this virus at present. If you suspect somebody is come from the Middle East and is exhibiting these signs and symptoms, if you don't already suspect COVID, MERS-CoV could be the potential culprit. And then there's SARS-CoV-2, which was detected in China in December 2019. Headache, fever, cough, muscle aches, vomiting, diarrhea, loss of taste and smell. In about 2% of detected cases, they had renal failure, respiratory failure, myocarditis, and or death. Treatment in the hospital included steroids and monoclonal antibodies. It still does, and they also have for those patients that uh, are are treated early. They also have Paxlovid now. Vaccine is available, and it is effective at preventing or diminishing the severity of the disease. Ebola, which was an outbreak, there was an outbreak. Ebola's been around for a while, but there was an outbreak in West Africa back in 2014. And that spread when people traveled to other countries. They would come back and they would have been exposed with Ebola. So they were looking for cases everywhere, right? I think in the United States, we actually only imported one traveler, if you will. The other cases that were identified in the United States during this time were related to going to the infected area and providing care directly to Ebola patients. So they were already high risk just by being medical providers to Ebola cases. The incubation period is 6 to 12 days after exposure. Symptoms may not appear for as long as 21 days after infection. There's some really good firsthand accounts from people in Nigeria where they had so many cases, but ultimately it came down to their determination to stay hydrated um, because Ebola basically takes all the water out via bleeding and fluid loss. So the big treatment that they found for Ebola was a lot of fluid replacement for individuals, and then some firsthand accounts out there that were just fascinating in their will to continue to drink and drink and drink and drink fluids, electrolytes, in an effort to try to maintain their ability to stay hydrated. If you suspect Ebola based on their travel history and or signs or symptoms, place a surgical mask on the patient, follow the PPE precautions by your local protocols and CDC, and of course notify the receiving facility. There are specific criteria that need to be followed for isolating these individuals. So, in travel medicine, it's important to be aware of travel acquired infections when you're assessing a patient who was recently outside of the United States. And there are lots of potential diseases out there, many of which are not necessarily infectious to other persons or communicable to other persons, I should say, but they are infectious to the individual. Um, they can present with a variety of symptoms, including fever, cough, vomiting, bloody diarrhea, body aches, rashes. Some patients can become extremely ill. There's some really nasty viruses and bacterials out there. Malaria is another big one. So that's a parasitic type infection, and that is a big killer worldwide. When you encounter an ill patient with a recent travel history, place a mask on the patient and gather as much information as possible. Make sure that that exposure control form is filled out. Remember, where did you travel recently? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who's sick? What type of foods did you eat? What was your source of drinking water? One of the biggest transfers of infectious diseases like cholera. Um, if you suspect the patient has a communicable illness, follow appropriate PPE and notify the receiving facility. So, your assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. And you, again, are the investigator, and you get to check out all of these, ask all of these neat questions, and try to get to the base of the story. The condition of the medical patient may not be as apparent as in a trauma patient, and it may not be as straightforward. Delays in attempt to diagnose the condition can be harmful, so do be very aware of the patient's level of extremis. Keep calm, use your patient assessment skills, treat the patient's symptoms, report to medical control, and transport the patient safely to the emergency department. Patients sometimes have more than one isolated problem, so be prepared to handle any combination of those conditions, including conditions of medical patients who've been involved in trauma. All right, so we have for you a few videos that we'll see in class. Those are related to this is This is a video of pertussis and what that cough sounds like because it is white. It's called whooping cough. I just wanted to point out to you too that at the end of all of these slides, you have access to all of those presentation slides. Don't forget, there's these questions out here. It has the question, it has the answer, and it has the reasoning for you in each of the slides. So there's always 10 questions at the end of every PowerPoint. Take a few minutes to go through there and ask yourself those questions to see how well you understand the information that you have read and or heard about.